Hello, my name is Dr. Sameh Shaheen. I'm Professor of Cardiology in Ain Shams University, and I'm honored to be with you in this review course. My topic today is about acute coronary syndrome. And as you can see from the title, that I will tackle the invasive management of acute coronary syndrome, particularly timing of this invasive management, and the basic technical aspects. The first part of my presentation will be related to STEMI, ST elevation MI, as a part of the big acute coronary syndrome. And I'm referring to this guidelines of the European Society of Cardiology. This actually is the latest guidelines, 2017, dealing with the management of STEMI patients. So I will refer in most of my slides to this recent guidelines. Let's start by putting this fact that the most important thing in treating patients presenting with ST elevation MI is reperfusion. And by reperfusion we mean is restoring the flow of the occluded artery. So we have to put all our efforts to open the artery in a timely fashion, that's in the proper time, because any delay in this will affect the myocardium of the patient and will let the patient pass into complications. So the first thing about reperfusion strategies is the decision that can be taken according to the time from symptom onset. So if the patient is presenting within the first 12 hours, this is the best or the ideal time or the ideal window to open the artery without major complications. So the first 12 hours is very important. But if the patient is presenting from 12 to 48 hours, this is another story, as I will tell you about the proper management, the proper way of reperfusion in this regard. So let's go to the first 12 hours. As I told you, we suppose that most patients will be wise enough, will be aware enough to reach the hospital within the first 12 hours of chest pain onset. In this regards, the doctor has two main options: either to open the artery by the primary PCI, and we have data and evidence that puts them as a recommendation class 1 with level of evidence A. So this is the highest recommendation in reperfusion, which is primary PCI. On the other hand, we have a second option, which is fibrinolysis. Fibrinolytic therapy can be an option in the first 12 hours, only in the first 12 hours can be an option. But we have three conditions. First, that PCI cannot be performed within 120 minutes. So this is the first condition to use fibrinolytic therapy, is that you cannot offer, or you are not able as a doctor or as a hospital to offer primary PCI within 120 minutes. In this delay, in this major delay, more than 120 minutes, fibrinolytic therapy will be a better option for your patient than waiting for more than 120 minutes. So this is the first condition to use fibrinolytic therapy. The second condition, as I've mentioned, to be within the first 12 hours. If the patient is presenting beyond 12 hours, then fibrinolytic therapy is not an option anymore. And you have to do primary PCI, whatever the time delay that you will wait for. So this is the second condition, is that the patient is presenting within the first 12 hours. The third condition is that you are having no contraindication, or your patient is having no contraindication to thrombolytic therapy. This is very important to think of, the contraindications of thrombolytic therapy, whether it's present or not. If not, then this is an option. Whether the patient is presenting in the first 12 hours or not, beyond 12 hours, fibrinolytic therapy is not an option. And number one, if you are not able to do primary PCI within 120 minutes or 2 hours, then fibrinolytic therapy might be a good option for this. And again, it's a class 1A recommendation. What about if the patient presents after 12 hours from chest pain? We consider this a late presentation. If this is the case, then you don't have any option other than primary PCI. Thrombolytic therapy will not work in this situation, and it's better to transfer the patient to primary PCI. If you don't have a cath lab ready for your patient, transfer your patient, whatever the delay, the time delay, because thrombolytic therapy will be useless. And what about if the patient is having no symptoms? This is a new indication for primary PCI. So from 12 to 48 hours, this is a new indication by the European Society of Cardiology. We are extending now the window of doing primary PCI. It's not only for the 12 hours limit. No, if the patient is coming after, say, 24 hours, after even 48 hours, you imagine after 2 days, and the patient is stable and he is having no chest pain, yet primary PCI is indicated. Although it's not a class 1 recommendation, but it's still a class 2A recommendation. So now we are extending the window up to 48 hours to do primary PCI for patients with STEMI, even if the patient is symptomatic. If the patient is asymptomatic, if the patient is symptomatic, then you can extend whatever the time, even 72 hours, even more, as long as the patient is still having chest pain or any signs of ongoing ischemia. It's still indication for primary PCI. The last thing I would like to mention in this regards is what about too late presentation? That's the patient presenting after 48 hours. Even after 48 hours, sometimes you can receive patients in your hospital. In this guidelines, in the European Society of Cardiology guidelines, it's actually contraindicated to do primary PCI or, of course, to give thrombolytic therapy in such cases. So beyond 48 hours, just give symptomatic treatment to the patient, just stabilize the patient, just reassure the patient and give him anti-ischemic and anti-failure treatment and statins and so on, but no indication for reperfusion. But you have to do some sort of assessment of residual ischemia later, maybe after 2 weeks, after 3 weeks, but never to do a primary PCI in this regard. This is very important. So I will just give you the same messages in these slides. The first one is a class 1A recommendation, is to open the artery. Reperfusion is a class 1A recommendation, as long as we are talking about less than 12 hours presentation, which is the ideal window for opening the artery. The second point is a primary PCI strategy is recommended over fibrinolysis. Always we are ensuring this to our doctors, that primary PCI should be your first choice and not thrombolytic therapy, because of the many evidence that we have, many trials, head-to-head comparison between primary PCI and thrombolytic therapy. There is no way to put them at the same level. But if the patient is reaching a hospital with no facility for primary PCI, then you have to weigh the delay. The delay to do the primary PCI is, if more than 120 minutes, then thrombolytic therapy might be an option. So the third indication of thrombolytic therapy is that the primary PCI cannot be performed within 120 minutes, and the patient should be within 12 hours, not more than this. Beyond 12 hours, there is no place for thrombolytic therapy. And definitely, you have to search for contraindications to thrombolytic therapy, like, for example, a history of brain trauma or intracerebral hemorrhage within the past 6 months or so, or severe hypertension, whatever the contraindications, a long list of contraindications that you might not offer thrombolytic therapy to your patient. If the patient is beyond 12 hours presentation, then again, primary PCI is the only option. And again, this is a class 1 level of evidence C recommendation. Now, remember that the window has been extended beyond 12 hours to reach 48 hours. From 12 to 48 hours, there is a place to do primary PCI, yet it is a class 2A recommendation, not a class 1 recommendation. There is no place of thrombolytic therapy beyond 12 hours. This is very important to remember, even if the patient is asymptomatic. And a class 3 recommendation is that beyond 48 hours, you don't have to do any reperfusion. The patient should be stabilized, and then think about non-invasive testing to assess whether the patient is having a stress test to assess whether he is having residual ischemia or not. There is a very important scenario in this reperfusion strategies, is that in the absence of ST segment elevation, a primary PCI strategy is indicated in patients with some critical conditions. So even if the patient is not presenting with ST elevation in the ECG, but the patient is having, for example, hemodynamic instability or cardiogenic shock, the patient deserves primary PCI. If the patient is having chest pain refractory to medical treatment, the patient deserves a look and an aim for primary PCI. If the patient is having life-threatening arrhythmias, VTAC or VF, and he received DC shock, again, this patient should be investigated, and primary PCI can be an indication. Mechanical complications like VSD or mitral regurgitation, again, is an indication for urgent intervention. Acute heart failure and recurrent dynamic ST segment or T-wave changes, even if the patient is asymptomatic but is having asymptomatic ECG changes suggestive of ischemia, again, this is an indication for primary intervention, even if the patient is not having a typical ST elevation in the ECG. A fifth scenario, this is again very important. Suppose a patient is presenting with ST elevation, and then you give him, for example, sublingual nitrates, and the patient returned back, the ECG returned back normal. This is an indication to primary PCI, or to send him for cath lab, or to send him home. No, again, the guidelines states that even if the patient's ECG returns back to normal, and the patient is not having chest pain, but he at any time was presenting with ST elevation ECG, then again this patient deserves a look with a coronary angio, perhaps within the first 24 hours, and this is a class 1 recommendation. So ST elevation returning back to normal, this is again an indication to see him on cardiac cath and coronary angiography. So now let's go to another parameter to assess the possibility of reperfusion. We talked about the timing of presentation, and this was very important. What about the mode or the place of presentation? So we talk about the time, now about the place or the site of presentation. So if the patient is presenting to a primary PCI center, a primary PCI capable center, that's a center working 24 hours, 7 days a week, this is again a straightforward decision. The patient should be rushed to the cath lab to do primary PCI, and the target time should be less than 60 minutes. What about a patient presenting to a non-PCI capable hospital? A hospital, a small hospital, perhaps in a remote village or a remote town with no facilities for primary PCI. Then the doctor should estimate and should calculate in his mind, actually it should be calculated before, whether transferring the patient and going to the cath lab for primary PCI will take more than 120 minutes or less. If less, transfer the patient to another big hospital with primary PCI. If the estimated time will take longer than 120 minutes, then please give the patient thrombolytic therapy as long as there is no contraindication, and then transfer the patient to primary PCI after giving the thrombolytic therapy. This is the conclusion of this slide. And again, I'm telling you that this number you have to remember is the 120 minutes. This is the separator between sending the patient without thrombolytic therapy to primary PCI or keeping the patient at your facility and giving him thrombolytic therapy. But remember always that once you give the patient thrombolytic therapy, you have to prepare him for transfer to the primary PCI center. Whatever the success you are seeing in your patient, the patient should be transferred to a primary PCI hospital because, again, remember that the guideline states that after thrombolytic therapy, all patients should be transferred for primary PCI in order, because sometimes there is a residual lesion that should be stented. So there is routine indication for routine PCI strategy from 2 to 24 hours. So after thrombolytic therapy, from 2 to 24 hours, even if the thrombolytic therapy is successful. I want to remind you with the time targets. This is very important. ECG should be done within 10 minutes of a presentation to your hospital. If the patient is presenting with with the chest pain, you have to do ECG to diagnose the patient within 10 minutes. Don't leave the patient with chest pain in the ER and do other jobs. ECG is very urgent, should be done within 10 minutes. And then you have to decide whether to do primary PCI or not, to transfer the patient for primary PCI or not, according to the time frame that you are expecting the patient to have. If less than 120 minutes, then transfer the patient. If more than 21 minutes or more than 120 minutes, keep the patient at your hospital and do thrombolytic therapy. If the patient is presenting to a primary PCI hospital, then the target time should be less than 60 minutes to pass the wire through the lesion. Very important. If the patient is transferred from a non-PCI hospital to a primary PCI hospital, then the target should be less than 90 minutes, 1.5 hours. Thrombolytic therapy should be started within 10 minutes from diagnosis with the ECG. This is again very important. And then an important, again, target is to do evaluation of the success of thrombolytic therapy within 60 to 90 minutes. So after finishing your thrombolytic therapy, whether it is streptokinase or RTPA or whatever, after 60 minutes or after 90 minutes, you have to do an ECG and assess the patient, whether the patient is having chest pain or not. If the patient is successful, you have to transfer the patient from 2 to 24 hours. If the patient has failed thrombolytic therapy, then this is an indication for urgent rescue PCI. Transfer the patient immediately to a rescue PCI. A few words about logistics of pre-hospital care. We have to do regional networks in every place. If you are working, for example, in a hospital in Cairo or in Alexandria or in even a small town, you have to prepare your team to work within a network. So there is a hub, should be a hub, which is the major hospital that you have a cath lab in it, and spokes, small hospitals referring patients to the hub. So this is what we call a network. This is very important in order to provide primary PCI to many patients as possible. Very important to design this sort of regional networks. Again, you should have a hub, a primary PCI capable hospital that works 24/7 and provides this service with no shut-off periods. And again, if the patient is diagnosed with ST elevation, you have to bypass the ER. You have to send the patient directly from the ambulance to the cath lab, as long as he has already proved diagnosis with the ECG. The ambulance teams should be trained and equipped to identify STEMI. We, in the Egyptian Society of Cardiology, are doing many training courses for the ambulance teams to do ECG and either to diagnose the ECG by themselves or to send it by perhaps WhatsApp or whatever the technique across the telephone to get the diagnosis. And very important to bypass the non-PCI centers. Again, if the patient in the ambulance is having chest pain, the team should be trained to bypass the non-PCI centers and to take the patients directly to a PCI-capable hospital. Again, of course, this should be designed through the Minister of Health rules and sort of network design. But please keep this in mind if you are having any role in designing such a network. I want to again remind you with some important procedural aspects of the primary PCI. So this is an indication, a class 1 indication to do primary PCI, as I've mentioned before. And if the patient is having recurrent ischemia after doing a primary PCI, then this is again an indication for a second look. Send the patient again. Perhaps there is a problem in the infarct-related artery. You have to return back to the cath lab. Again, this is a class 1 recommendation. Always put a stent in a primary PCI scenario. Very few cases in which you are sure that doing a simple balloon will be sufficient. No, most of the patients, actually 99% of the cases will need stenting. Again, very few cases will suffice with thrombus aspiration, and you think that there is no need to put a stent in a healthy artery. Again, this is a very minor percent of patients. Most of the patients, as I've mentioned, will need a stent, and this is a class 1A recommendation. What type of stent? Again, we are talking now about the new generation drug-eluting stents. Most of the cases of Egyptian patients now are taking this new generation drug-eluting stent. There is no place for bare metal stents anymore in this scenarios, because a few years ago there was a debate about the safety of new generation drug-eluting stents in heavy thrombus burden. No, it is safe. We have proved this in many trials, so there is no place for bare metal stents in this regard. The radial access, again, if there is an experienced radial operator, it's better to do a radial access over a femoral access. This is very important. Remember that routine thrombus aspiration is not indicated anymore. It's a class 3 recommendation. It's contraindication to do routine thrombus aspiration. Sometimes you have a huge artery with a huge thrombus burden. No problem in using thrombus aspiration, but should not be a routine in all your patients. This is a new guideline recommendation. As the same also applies to deferring stenting. Again, sometimes you have a patient with heavy thrombus burden, you put a balloon or you do inflation of the balloon, and then you send him to the CCU for overnight 2B3A antagonist in order to dissolve the thrombus and have a better look after 2 days, maybe after 48 hours. This should not be routine. This is only for very special cases, not routine. Deferred stenting is not safe. The patient might have an acute occlusion again at night. So please, this should not be your routine stenting. It's a class 3 recommendation. What about the non-infarct-related artery, a patient presenting with STEMI with multivessel disease? Now the new recommendation is to think of doing the non-infarct artery before hospital discharge. This is a class 2A recommendation. We have more evidence that this is safe and beneficial to the patient. So if the patient is having a non-infarct artery lesion, even if it is stable, then it's better to do it before hospital discharge. What about patients presenting with cardiogenic shock? This has been, again, put as a class 2A recommendation. It's not a class 1 anymore. It has been downgraded to be a class 2A recommendation to do the non-culprit artery or the non-infarct related artery lesion during the index procedure. during the index procedures. So this is not class 1, but it's a class 2A. So it should be considered to do non-culprit lesions in patients with cardiogenic shock. CABG is very rarely referred to in a setting of ST elevation for the culprit artery. But for the non-culprit, this is another scenario. This is another issue. For example, if the patient is having left main, for having a tight calcific CTO or tight lesion, then CABG might be considered in this regard. This has been the first part of my presentation. The second part is about non-ST elevation. Again, I'm referring to the European Society of Cardiology in 2015, and this should be our standard in this regard. So this is the famous slide that, again, we are talking about reperfusion strategies in patients presenting with chest pain but without ST elevation, so non-ST elevation MI. What can we do about this? This is very important that reperfusion is not routine for all patients like the case with STEMI. No, in non-STEMI we have to risk stratify our patients. And by the risk stratification, we will allow these patients to be stratified for the urgency of doing cath and doing coronary angio and perhaps intervention. So if a patient is presenting with these unstable and very high risk criteria, then this is an indication for PCI within 12 hours. Within 2 hours. So this should be treated as seriously as a patient with primary PCI, with ST elevation, although the ECG is not showing ST elevation. Patients with hemodynamic instability, recurrent chest pain, life-threatening arrhythmias, mechanical complications, acute heart failure, recurrent dynamic. We mentioned this in the ST elevation slides. If the patient is having an ECG with no ECG ST elevation, but with these high-risk criteria, you should treat him as serious as a patient with ST elevation within 2 hours. A less invasive approach is a patient with, for example, troponin positive or dynamic ST changes or Grace score more than 140. In these high-risk patients, you should consider coronary angio and perhaps PCI in the first 24 hours. You have space, you have time to breathe and to get your staff and to stabilize your patient. Perhaps to the next morning, you can send the patient for the cath lab and with a vision of PCI. Less aggressive patients or less unstable patients, those can be treated within the first 72 hours. Like diabetics, like patients with renal insufficiency, ejection fraction less than 40%, post-MI angina, recent PCI, or prior CABG or Grace score from 109 to 140. All these patients are indicated for invasive management, but perhaps within 72 hours. You don't have to rush. But still, before sending patient home, before discharge, these patients should be catheterized and coronary angio is indicated. In all other cases, without the previously mentioned criteria, maybe you can do a non-invasive test, of course with imaging, to decide whether the patient needs coronary angio or not. What about the PCI procedure itself? What are the guidelines in this approach? Again, radial approach is preferred over femoral, and this is a class 1 recommendation. Again, using new generation drug-eluting stents compared to bare metal stent, again, is indicated in this regard. And again, what about the scenario of multivessel disease? You have a patient with chest pain, ECG shows ST depression or T-wave inversion, and troponin is positive, and you do coronary angio, and you find that the patient is having multivessel disease. Do you do PCI or you do CABG? Again, you have to depend or to rely on the clinical status of the patient, whether he's having urgent situations or not. The comorbidities, for example, diabetes or CKD, it will decide, it will be an important issue in the decision. The age of the patient perhaps is again very important. The risk of doing CABG for this patient, the syntax score, which is the complexity of the coronary anatomy and the disease severity. Again, all this should be discussed within the local heart team, and whether the patient can be treated with perhaps a CABG or PCI, or maybe medical treatment, again, is an option. So this is the situation in case of multivessel disease, always to take the decision within the heart team protocol. What about patients with high bleeding risk? Again, even in patients with high bleeding risk, using a new generation drug-eluting stent is better than bare metal stent. The benefits of new generation drug-eluting stents is far, far better than a bare metal stent as regard these. Even if the patient is, you are afraid of a prolonged dual antiplatelet therapy, now the high patient risk, now the new data permits in extreme situations to stop one of the dual antiplatelet therapy after 3 months, which is the minimum, and sometimes in, for example, some of the new stents, you can stop one of the the antiplatelets after 1 month. But this is very rare situation. But I'm sending you this message that even in this situation, a drug-eluting stent is better than a bare metal stent. Think about it very thoughtfully because of the restenosis rate, which is very high in bare metal stent. Elderly patients. What about a patient, for example, 85 years old? Do we treat him the same as a young patient 40 years old? Of course, no. Still, there is an indication for invasive strategy in these elderly patients, but you have to be very careful and you have to evaluate the potential risks and benefits. You have to estimate the life expectancy of this patient, the activity of this and the quality of life of this old age, the comorbidities and the frailty, and the patient preferences. All this is different from a young age. So invasive strategy is indicated, but after evaluation, all these circumstances. What about diabetics? Diabetics are very high risk patients. Invasive strategy is indicated. You have to monitor and take care of his renal functions. 2 to 3 days after the coronary angio, you have to do renal assessment, creatinine level, and so, because these patients are liable for acute renal failure. So good hydration is indication. And again, we have to highlight the importance of using new generation drug-eluting stents in diabetic patients, particularly when compared to bare metal stent. CABG is important to be considered, and it's better than PCI in multivessel disease. The only indication of PCI in diabetic multivessel disease are those patients with syntax score less than 22. In this situation, you might consider PCI, and it's a class 2 indication if the syntax score is less than 22. But otherwise, CABG has better prognosis and better long-term results in diabetic patients. You know that diabetic patients need special management, special treatment. Similarly, the CKD patients with chronic kidney disease, you have to take care of the hydration of these patients before coronary angio, because these patients are liable to have acute renal failure after coronary angio. You have to estimate the risk-benefit ratio of doing invasive procedure in this regard. Drug-eluting stents, new generation, is very important rather than bare metal stents in CKD patients. Again, CABG, similar to diabetic patients, should be preferred over PCI. But again, this depends on the life expectancy of your patient, because sometimes you have a very end-stage CKD patients, and you are not expecting the patient to live more than 1 year. So this, you might not consider CABG for such a situation. Otherwise, PCI might be considered in this regard. What about acute heart failure? Again, echo is very important to diagnose the different causes of acute heart failure, patient presenting with chest pain and acute pulmonary edema. You have to do urgent echocardiography. You have to do immediate coronary angiography. Again, this is one of the indications of immediate coronary angiography to diagnose the cause of acute heart failure. Very important to do immediate PCI if this is the cause of heart failure. Immediate PCI is indicated, or emergency CABG if the patient is having mechanical complication, and of course a heart team is indicated if you are thinking of CABG. Mechanical complications is an indication for intra-aortic balloon pumping. It's a class 2A recommendation. And short-term mechanical circulatory support with perhaps Impella or whatever, or ECMO, might be indicated in patients with cardiogenic shock. Still, the evidence is not so strong. It's a class 2B recommendation. Remember that routine intra-aortic balloon is not anymore indicated in patients with cardiogenic shock. Case by case decision. We should use intra-aortic balloon in indicated cases, particularly in patients with mechanical complications presenting with cardiogenic shock. With this, I end my talk. I thank you very much for your interest and for following me in this lecture. And of course, through various interaction, I'm ready to respond to whatever comments, whatever questions, and good luck to all of you. Thank you very much. Bye-bye.